Good evening, aspirants, and good evening, sir. Today's class is on valvular heart disease, and our speaker today is Dr. SUBHRA Das. He is the senior consultant, interventional cardiologist, Apollo Multispecialty Hospital, Kolkata. And our moderator today is Dr. JAYANTA Sharma. He's the professor and senior consultant, geriatric and internal medicine, Apollo, Kolkata. So, sir, you can start the class.
Thank you, Sushmita. Thank you, the Farz Academy. Good evening, all the participants and all the delegates over here. It's a nice evening in 25th January. It's a chilly weather in outside. And our distinguished speaker, Dr. Shankha Das, is with us. He is one of the senior most consultant interventional cardiologist in our beautiful city of Calcutta. He is currently attached in Apollo Clinicals Hospital as a senior consultant, doing a large and multiple intervention in his field. He is also an expert of the valvular heart disease. Previously, in another topic or another class, we have been talked about the part one of this valvular heart disease. During that time, Dr. Shankha was telling that valvular heart disease is such a large topic and large subject, it is cannot be possible to complete it only one single lecture or one single class. So it has been switched over or it has been splitted over one or two or three classes, depends upon the contents of the class and these things and the participants participation. So it has been splitted into two and three classes. Valvular heart disease, all of you know, in rheumatic heart disease and valvular heart disease, one of the core curriculum activity in cardiovascular disease in India as well as in Western world. But the number of valvular heart disease still it's high in the southeastern India, and Dr. Shankho is expert on that. And today I am requesting Dr. Shankho Subhra to take over the class because he is too good on this class. And last class also, whenever we was listening, he was telling so deliberately and each and every topic minutely. I think so. All the students who are presenting over there, they will definitely get some advantage with these classes and these things. Today I am having another program. Epicon is going on in Calcutta and these things, and I am a organizing committee member, so I am little bit busy on that part also. So after few minutes, I'll leave the show and I'll ask Dr. Shankar Subhra Das to continue the class, and I'll later on join with you people. So now the session is with Dr. Shankar Subhra Das. Sir, please just take over the mic and start the classes for today.
Thank you, Dr. Sharma, for your very, very kind words and your excellent introduction. So,
I'm just one interruption. I'll
yeah.
leave the session in between, okay? I'm
Okay,
having
sure. I
another
know
commitment.
Apicon is going,
Ha,
so
ha,
you'll be busy there as well. But
ha.
I would request you that if possible, please join in between for some time.
Yeah, sure. I'll try.
Sure. Thank you so much. So, let me go through the discussion today on rheumatic heart disease. The first discussion was basically on rheumatic fever and a bit of aortic valve disease. And today we will discuss basically on mainly on mitral valve disease. So let me go on straight to the discussion on mitral valve disease. If you have any questions, the listeners, if you have any question in between, you can interrupt and ask me. I will be happy. So if you see here that mitral valve involvement, it happens almost in 75% of patients of rheumatic heart disease. Approximately 73% of rheumatic mitral valve involvement happens with the mitral valve, out of which 37% is pure mitral stenosis, and the remaining is basically mixed mitral stenosis and mitral regurgitation. 25% of mitral stenosis patients have a multivalvular involvement in the form of aortic valve mainly. 75% at presentation have moderate or severe mitral stenosis. And two-thirds of mitral stenosis patients, they are mainly women. So these are some of the statistics that you need to remember, especially the medicine students as well as the DNB students. You may be asked that what are the statistics of mitral stenosis in India? So two-thirds of the patients are female. 75% at presentation have moderate or severe MS. 25% of mitral stenosis patients have an associated aortic valve involvement. And mitral valve involvement is basically the brunt, 75% of total rheumatic heart disease. Now, what is the etiology? As we know, the commonest cause is rheumatic heart disease. Besides, it could be mitral annular calcification. It could be congenital mitral stenosis that we cause parachute mitral valve. It could be systemic lupus, connective tissue disorders. It could be some mucopolysaccharidosis like Fabry's disease, Gaucher's disease, and others, Whipple's disease. Or it could be secondary to some drug therapy like antifibrotic drugs, methotrexate. But remember that the most commonest part of cause of rheumatic heart disease in our part of the world, it is still rheumatic heart disease. And in western part of the world, it is mainly degenerative, that is mitral annular calcification. So these two you need to remember. Besides, congenital MS is quite rare. These patients do not survive for a long time. And there are some other connective tissue disorders which rarely affect the mitral valve. Now, what are the symptoms? Now, if you go through the symptoms, obviously the commonest symptom is dyspnea due to reduced lung compliance because there is pulmonary venous hypertension, there is pulmonary capillary hypertension, and there is transudation of fluid inside the pulmonary capillaries. There may be acute onset of dyspnea at night, and often, patients complain that suddenly they got up from the bed at night and they runs to the window for ear hunger. So this is called PND, paroxysmal nocturnal dyspnea, which is a very classical symptom of mitral valve disease. And you may be asked in the exam that what are the causes of PND. So one is redistribution of fluid from the extravascular to the intravascular compartment as the patient assumes a supine position, increased venous return to the heart, elevated diaphragm during lying down position, which reduces the thoracic capacity, reduced sympathetic drive, and a central respiratory depression. So all these factors together leads to paroxysmal nocturnal dyspnea. Fatigue is quite common due to low output state besides right heart failure. Chest pain can happen in these patients because of right ventricular ischemia secondary to pulmonary artery hypertension. Now, this low cardiac output patients, as you know, that mitral stenosis is a low cardiac output state. So often these patients land up with atrial fibrillation. They can have an embolic symptom, and they often land up with syncope or transient ischemic attack. They often have palpitation secondary to atrial fibrillation or right ventricular volume overload. So what more symptoms? Hemoptysis. Hemoptysis is quite rare nowadays in patients of mitral stenosis. But still, you may be asked in the exam, the examiner may ask you what are the common causes of hemoptysis in a patient of mitral stenosis. So it could be acute pulmonary edema that leads to pink frothy expectoration. It could be simple infection that is like LRTI or winter bronchitis. It could be a pulmonary infarct, or it could be pulmonary apoplexy due to rupture of the bronchial veins. Examination. So when you examine a patient of cardiovascular disease, it starts with inspection, palpation, and auscultation. Besides, you also do an inspection, a thorough general survey, and a thorough inspection of the patient. So a mitral stenosis patient, if he is dyspneic, then obviously he will have an anxious look. He will be dyspneic, he will be tachypneic, he will be upright, he may be needing on oxygen, and there may be a mitral phasis, which is not common in this part of the world, but this is quite common in Western world, where the fairer complexions are much more common. The patient may have a bit of tachycardia and tachypnea. Now, if the patient is connected to a monitor, you will see that the heart rate is fast. There could be an irregular heart rate secondary to atrial fibrillation. You have to do a complete inspection of the chest. So you have to look for scar marks, either a midline scar or a submammary scar, which is an indicator of previous procedures like a closed mitral valvotomy or an open scar in the form of an open mitral commissurotomy or mitral valve replacement. Next, we look for the apex beat. Normally in mitral stenosis, the apex beat is not well visible because in mitral stenosis, there is mainly right ventricular hypertrophy instead of left. So right ventricular apex is a diffuse apex and it is not very localized. So you can't make out the apex on inspection. So when you palpate the patient, you can make out the apex, but it may be a diffuse apex as the apex is formed by right ventricular hypertrophy. So a diffuse apex, and you can't differentiate this apex from the parasternal pulsation. An RV type of apex with lateral retraction. Sometimes you may get a localized apex due to an LV apex if the left ventricle is palpable. Now we often call it that it is a tapping apex. So what is the tap? So tap is nothing but the palpable first heart sound. If the apex is formed by LV, then you can get a localized tapping apex secondary to the tapping first heart sound. So which means a just palpable apex. And if it is an RV apex, mostly it is a diffuse apex. You can't localize the apex with a single finger. And the apical impulse basically emerges with the parasternal heave. Now, if the patient have a pulmonary hypertension with right heart failure, you will get a parasternal heave. And you can also make out a palpable pulsation in the pulmonary area, which can be a palpable P2. What about the heart sounds? First heart sound is loud S1. Now, loud S1 means the integrity of the mitral valve apparatus is intact. Now, what happens in mitral stenosis? That the valves are basically thickened and there is limited mobility of the valves. So the valves remain open for quite a significant part of the diastole and the valves remain wide open. Now the intensity of the S1 depends upon the cooptation velocity of the mitral valve as well as the initial position of the mitral valve from which they close. So longer is the diastole, longer is the time that the mitral valve remains open in a wide position, and due to thickening, the mitral valve, the velocity, it takes longer time for the mitral valve to close. So a wide initial distance and a very fast cooptation velocity when it closes. So these two are the basic cause of a loud S1. So large distance covered with a high cooptation velocity from the initial lower position at the onset of systole. So that is the cause of a loud sharp S1 in mitral stenosis. So the valves are quite wide open. They are quite in a low position at the onset of systole. And as soon as the contraction begins, LV systole, these valves, they have a very fast cooptation velocity and they close very fast. This one may be soft if it is calcified. So a soft S1 means that there is significant calcification of the mitral valve. There may be some other possibilities like if the right ventricle is forming the apex or if there is a significant pulmonary artery hypertension, so the flow across the mitral valve is reduced, you can also get a soft S1. Opening snap. Now, opening snap is a sharp sound that is produced due to abrupt halting of the opening of the mitral valve. So it is a sound produced due to abrupt stoppage and tensing of the mitral valve with the onset of diastole. Sharp high-pitched sound, which is best audible just inside the apex beat. Now, opening snap is basically a diastolic sound. It begins after A2. That is in between S2 to S1 is the opening snap. Now, there is a gap between A2 and the opening snap, which is normally in between 40 to 120 milliseconds. A sharp opening snap means that the valves are quite pliable. And severity of mitral stenosis is determined by A2 opening snap gap. If it is shorter is the A2 opening snap gap, severe is the mitral stenosis. Now for the DNB trainees, this is a special something that I will mention, that this A2 opening snap interval can have two components. One is A2 to the onset of mitral valve opening, and second is the onset of mitral valve opening up to the opening snap, that is the abrupt halting of the valves. So there are two components. One is A2 MO interval, that is the isovolumetric relaxation interval, when the A2 between the A2 and the beginning of the opening of the mitral valve, that is the A2 MO gap. And the other one is the mitral valve excursion time, that is from the mitral valve opening up to OS. Now, if the A2 MO gap is less than 30 milliseconds, it is severe mitral stenosis. The MO-OS gap is more or less constant, remember. It is the A2 MO gap that is much more sensitive in determining the severity of mitral stenosis. So A2 MO gap is the true indicator of LA pressure, and it is a true indicator of severity of mitral stenosis. MO-OS gap is a function of the mitral valve mobility, and it may prolong with mitral valve calcification. What do you get an auscultation? So you all need to learn by heart the classic murmur of mitral stenosis. So it is a mid-diastolic rumbling murmur with pre-systolic accentuation, which is best heard with the bell of the stethoscope, with the patient in left lateral position, with breath held in expiration. So that is the classic description of the murmur of mitral stenosis, and that is one most of the examiners want to hear from you. And I would ask all the students that please learn this proper description of a mitral stenosis murmur. Now remember, mitral stenosis murmur is a diastolic murmur which may be associated with a thrill. But normally, thrill is normally related to a systolic murmur. Normally, it is the grading of the systolic murmur where thrill comes, not for a diastolic murmur. But MS murmur may be associated with the thrill. Well, some examiners accept it, some examiners may not. Next, it is the length of the murmur that is related to the severity of mitral stenosis, not the loudness of the murmur. So remember, it is the length of the murmur, not the loudness of the murmur, that is related to the severity of MS. And if the patient goes to atrial fibrillation, then it is only the early diastolic part that is audible, but you can't hear the pre-systolic accentuation, which is lost. Now, in case of severe pulmonary artery hypertension with right heart failure, what happens? There is significantly less flow through the mitral valve due to pulmonary hypertension. So what happens? The murmur gets absent. There will be a soft S1. The opening snap will also be soft or as absent. The apex will be shifted backwards because the RV forms the apex, and there will be low flow across the mitral valve. Next, if the patient is in pulmonary artery hypertension, he will get a loud second heart sound. The second heart sound has two components, A2 and P2. It is only the pulmonary area where you can make out A2 and P2. In all other areas, it is basically A2 that you hear. Now, in mitral stenosis with pulmonary hypertension, it is P2 that gradually gets loud. So during inspiration, you can make out the A2-P2 split. The P2 is loud. And greater is the pulmonary artery hypertension. Gradually, the A2-P2 comes closer, and it could be a single loud P2, A2-P2 merges. Now, pulmonary hypertension can lead to rarely to an early diastolic murmur of pulmonary regurgitation. It is just for academic interest, but normally, rarely we hear a murmur of pulmonary regurgitation. You can hear a soft murmur of tricuspid regurgitation in the tricuspid area, which may be accentuated with inspiration or leg rise, and that is the murmur of TR, which signifies that the patient is at least having a PA pressure of more than 50. But be very careful before committing to a murmur of tricuspid regurgitation, because this murmur is a very, very low-pitched murmur. Now, what are the mimickers of opening snap? So, opening snap is a sharp, high-pitched sound. Can you please mute your mic? So opening snap is a sharp high-pitched sound which is best audible just inside the apex. As I told you, that wider is the A2OS gap, lesser is the severity of stenosis, shorter is the A2OS gap, severe is the stenosis. Now A2OS gap widens with standing, but there is no change with respiration. The commonest mimickers of opening snap is LVS3, Tharat sound, which is best audible over the apex, better audible with expiration. Second is split S2. It could be an A2, P2. P2 may be confused with an opening snap. And it could be a pericardial knock as well, which is also a diastolic sound. So these are the common close mimickers. You may be asked, what are the mimickers of opening snap? But remember, the opening snap is a very, very sharp, high-pitched, localized sound, which is best audible just inside the apex. So, and it is not audible in other parts of the heart. So there is less possibilities that you will miss an opening snap if it is present. Now the examiner may ask you that what are the causes of mid-diastolic murmur in the apex? Forget about dramatic mitral stenosis. Tell me the causes of mid-diastolic murmur in the apex. So besides dramatic mitral stenosis, it could be mitral annular calcification, degenerative mitral valve disease that is quite common in the Western world. It could be parachute mitral valve. It could be a left atrial myxoma where the murmur may vary with posture. It could be a ball valve thrombus secondary to endocarditis or a left atrial thrombus. It could be a cord triatriatum. It could be an Austin Flint murmur secondary to aortic regurgitation. It could be flow murmur secondary to severe MR. Or it could be a flow murmur secondary to post-tricuspid shunts like VHD or PDA. So there may be so many possibilities where you can make out a diastolic murmur in the mitral area. And remember, even a pre-tricuspid shunt like ASD, this is also a very close mimicker of mitral stenosis because in ASD, there is increased flow of blood across the tricuspid valve, which produces a functional tricuspid stenosis, and you get a diastolic murmur in the tricuspid area with the loud T1 component. So many times we may confuse ASD as mitral stenosis. Now chest X-ray. You will be given a chest X-ray in exam of mitral stenosis and you will be asked about what are the findings. So do learn chest X-ray in patients of mitral stenosis. Now fluoroscopy is normally not done routinely in a patient of mitral stenosis unless the patient goes for a BMV or a surgery. So chest X-ray may show a double density on the right border due to LA enlargement, which is called double contour of the right shadow. There may be widening of the carinal angle due to LA enlargement. There may be LA appendage enlargement causing bulging below a pulmonary artery segment. There may be straightening of the left heart border. There may be pulmonary venous hypertension, which is indicated by upper lobar venous diversion, which indicates that the LA pressure is at least 15 millimeter of mercury. Now, if there is significant increase in pulmonary venous hypertension, with exudation of fluid into the interstitium, you can get a hilar haze, peribronchial coughing, Curly's B lines, thickened interlobar fissures, and all this indicates an LA pressure more than 20 millimeter of mercury. So, if you see this slide, this is the aortic knuckle. This is the pulmonary bay, which is dilated. This is the left atrial appendage, and then the left ventricle. So there is a straightening of the left heart border. And on the right side, you will get a double contour due to border of right atrium and left atrium. So the outer border is basically the right atrial border, and you can also make an opaque border inside, that is basically the left atrial border. So double contour is very prominent. There may be widening of the carinal angle more than 70 degrees, especially elevation of the left main bronchus due to left atrial enlargement. There may be prominence of the left atrial appendage. There may be prominence of the pulmonary bay. and there may be straightening of the left heart border. And the apex, it could be an RV apex if there is significant pulmonary artery hypertension with RV hypertrophy, and you can get an upturned apex, which is basically an RV apex. If there is significant pulmonary venous hypertension, you can get upper lobar venous diversions, which indicates a left atrial pressure of at least 15 millimeter of mercury. And if there is significant increase in LA pressure, then you can get prominent hilar shadows, that is exudation of fluid into the interstitium. You can get Curly's B lines or prominent interlobar fissures. You can get a bit of pleural effusion. You can get speckled shadows in the lungs secondary to pulmonary hemosiderosis. In the radiology exam, the examiner may ask you what is the indicator of RA dilatation in mitral stenosis in chest X-ray. So if the right atrial border is more than 55 millimeters from the midline, occupying more than 1/3 of the hemithorax transversely, more than half of the hemithorax vertically, and the right atrium is occupying more than 3 anterior intercostal spaces, that is an indicator of right atrial enlargement in chest X-ray. Remember, if it is an older examiner, he may ask you to show how do you make out right atrial enlargement in chest X-ray. Dilated main pulmonary artery, the right lower pulmonary artery at least more than 15 or 16 millimeter in diameter is also an indicator of pulmonary artery hypertension. And as I told you, you can get small speckled shadows due to pulmonary hemosiderosis. ECG. So ECG shows a normal sinus rhythm. There will be left atrial enlargement. So you can get a prominent biphasic P wave in V1, and the negative component will be very prominent due to left atrial enlargement. So you can see the biphasic P wave with a deep negative P here in left atrial enlargement. And there will be a prominent R waves in V2 or V3, which signifies RV prominence. And you can get a right axis because of right ventricular hypertrophy. If you see the axis, it is mostly right axis. Besides, you can also get a double peak shadow due to left atrial enlargement. It is not present, but normally in inferior leads, P waves, you can get a double peak shadow. And you can also make out an irregular rhythm secondary to atrial fibrillation. Now this Wilkins scoring, this is basically an echo finding. Now I know it is not so important for those patients who are studying medicine, but for those patients who are in cardiology, for them you need to know the Wilkins scoring properly, because it is still used to grade the severity of mitral stenosis. And you need to remember the 4 points: mobility of the mitral valve leaflets, thickening of the leaflets, calcification in the leaflets, and thickening of the subvalvular apparatus. And all these 4 criteria has been classified, has been given 4 points, and you get total 16 points. And if the Wilkins score is below 8, then it means that the valve is pliable. It is a favorable valve for balloon mitral valvotomy. If the Wilkins score is at least up to 10, then also you can go for a balloon mitral valvotomy. But if it is more than 10, then the valve is unfavorable for a balloon mitral valvotomy, and better we should proceed for a surgery. So Wilkins scoring is still important to learn, and you may be asked. Now there are some scattered pictures of echocardiography. Since this is a class mostly including both medicine as well as DNB cardiology students, so I have not included echo totally, but I have just shown you a few scattered pictures on echocardiogram. Now, as we know that in mitral stenosis, the left atrium gradually becomes enlarged, and you can get a thrombus inside the left atrium, which is called a ball valve thrombus, which basically migrates from the left atrial appendage, and it can intermittently occlude the mitral valve, producing a picture like mitral stenosis, or you can get significant contrast, dense contrast inside the left atrium, which is called spontaneous echo contrast. Nowadays, if you get significant spontaneous echo contrast, then it is better to put the patient on long-term anticoagulants, which was not previously there. Now, normally what you do is that we do an apical four-chamber view of the mitral valve. So you can see this one. This may help you. This is a parasternal long axis view of the heart. Many of the DNB students must be knowing it. This is the aorta. So this is the aorta. This is the left atrium. This is the left ventricle. This is the right ventricle. And you can see the mitral valve leaflets. You can see it. It is doming. It is the doming of the leaflets due to limitation and thickening of movement, which is very common in rheumatic mitral stenosis. And this is a parasternal short axis view at the level of the mitral valve. And this globular opening or annular opening is basically the mitral valve annulus. And you can do a planimetry, that is, you can calculate this mitral valve area and know that what is the exact area. What is the normal mitral valve area? It is 4 to 6 centimeters square. If it is below 2, then we call it mitral stenosis. And nowadays, if it is below 1.5 centimeters square, it is a severe mitral stenosis. Now, this is a case of severe mitral stenosis where this is the left atrium, this is the left ventricle, this is right ventricle, this is right atrium, this is the tip of the mitral leaflets, and this patient probably have both mitral stenosis and mitral regurgitation. You can see here. So this is left ventricle, this is left atrium, right ventricle, an apical four-chamber view. And this blue color is the regurgitant jet of blood that is coming along the mitral valve, along the lateral wall of the left atrium up to the posterior wall. And this is basically a severe mitral regurgitation. Now, when you keep the cursor along this mitral valve and you give continuous wave Doppler or CW, then you get this picture. What is this? This is the tracing of the pressure gradient across the mitral valve. Tracing of the pressure gradient across the mitral valve. What happens? When you put a cursor at the mitral valve, you get the flow, mitral flow to the ventricle, LA to LV flow. Now, normally we know that there are two phases of LA to LV flow, the E wave and the A wave. The early diastolic flow and the terminal atrial contraction flow. But in mitral stenosis, both these waves merge with each other. The E and the A, they merge with each other and we get a continuous flow like this, continuous flow like this. And when we trace this entire flow, this is called the time velocity integral of the mitral valve flow, then you get the velocity as well as the pressure gradient. You can see here that the mean pressure gradient is 24. If the mean gradient is more than 10, then we call it severe mitral stenosis. Now here the pressure is 24, so it is a very severe mitral stenosis. So you get the velocity, you get the time velocity integral, you get the maximum pressure, you get the mean pressure. And also there is another issue that is called the pressure half time. It is the time required for this peak pressure to become half. So by time this pressure half time method, it helps us to calculate the mitral valve area by pressure half time. It is an automatic algorithm that is given in the machine, and by this pressure half time, that is the time required for the pressure to become half, it helps us to know the mitral valve area. What is this? This is basically an M mode which is placed across the mitral valve, and normally you can see this small box. Normally in a healthy mitral valve, when we place this M mode, you can see this pattern which is here. You can see this pattern. This is the pattern. So this is the pattern, the anterior and the posterior mitral leaflet motion in M mode. The DE slope. Now what happens due to limitation of mobility of the anterior and the posterior mitral leaflets, these leaflets almost fuse with each other. You can see there is no net gap between the AML and the posterior mitral leaflet. There is no net gap. There is loss of the EF slope or loss of the DE slope. So that is what happens in the M mode in mitral stenosis. And this was what I was telling you, that when you calculate the mitral valve area in short axis view at the level of the LV, then you can get the exact area. So normally it is 4 to 6 centimeters square. If it is severe, it is less than 1. But nowadays, if it is less than 1.5 square centimeter, we call it severe mitral stenosis. So this plane is basically this one. This is left atrium. This is left ventricle. So this is the plane where you do a planimetry to get the exact area of the mitral valve. Remember that mitral valve area can be calculated in various methods. One is the planimetry, one is the pressure half time method, one is the PISA method. But remember that planimetry is the best method of calculating the mitral valve area. Planimetry will never deceive you. And the other methods have many limitations. Now, stages of mitral stenosis, well, that is called at risk, progressive, asymptomatic, and symptomatic. I will just discuss the last two ones. So, asymptomatic severe mitral stenosis, where there is diastolic doming, there is commissural fusion, the area is less than 1.5 square centimeter, and the diastolic pressure half time is more than 150 milliseconds. Same criteria when the patient becomes symptomatic, then it is called symptomatic severe mitral stenosis. What are the complications of mitral stenosis? Obviously, you know it, atrial fibrillation. And the atrial fibrillation carries a very high risk of embolism to the brain, TIE or embolism. Secondly is pulmonary artery hypertension, right ventricular failure, RV ischemia. Now, the prevalence of AF increases with age. So, 20% develop atrial fibrillation over the period of 6 years. An annual rate of embolism and death is almost 3.5 to 6% per year. Just remember these statistics because you may be asked. Now, what is the control of therapy? Rate control. You can use rate control. You have to use vitamin K antagonist if the patient is in atrial fibrillation. You have to use vitamin K antagonist if there is a left atrial appendage clot, if there is an LA thrombus, or if there is a spontaneous echo contrast. So all these are indications of initiating vitamin K antagonist. It is unlikely to achieve sinus rhythm in a patient of mitral stenosis if the patient is in AF because of the structural cause. There is already an obstruction. So it is very, very unlikely that you will achieve a sinus rhythm after cardioversion. But in some books, it is written that after doing a BMV, you can at least try to achieve a DC cardioversion to achieve a sinus rhythm. Pregnancy and mitral stenosis. This is something which we very commonly encounter in our practice. I think medicine students, DNB students, a lot of them have encountered it in their practice. Yes. So 25% of mitral stenosis, they are first detected during pregnancy. Just imagine. Before that, this is silent. It is the pregnancy that leads to the diagnosis of mitral stenosis. And the peak risk of heart failure is actually when the mother has maximum fluid overload in between 24 to 30 weeks of pregnancy. And 1/3 of MS patients that develop symptoms during delivery or during the first 7 to 24 hours postpartum. So to shortcut the pregnancy, you can give an elective lower segment cesarean section or outlet forceps. Now what happens that after delivery, there is decompression of the uterus or the inferior vena cava. So there is increased venous return following decompression of the IVC, and there is auto transfusion of blood from the uteroplacental bed. So these cause to a large volume overload to the central cardiopulmonary circulation, which leads to decompensation. So untreated severe MS, it should be considered as a contraindication for the mother to go to pregnancy. Now, pregnancy and mitral stenosis. Normal pregnancy sometimes is a big mimicker of mitral stenosis. Why? Because even a pregnant mother can have vasodilatation, can have tachycardia, can have hyperdynamic circulation, can have bipedal edema, can have a loud S1 due to increased blood flow across the mitral valve, and can have flow murmurs. So, a pregnant mother, if you auscultate a pregnant mother, many times you can feel that this mother may have a mitral valve disease. So in these patients, if you do a mitral valve pressure study or continuous wave Doppler study or pressure half time study, many times you may be fooled that this patient probably have a mitral valve disease. So always go for a mitral valve area planimetry, which is a gold standard to diagnose mitral stenosis instead of whatever shows the pressure half time. So if a pregnant mother with mild mitral valve disease may be having symptoms, always do a mitral valve area planimetry to stamp the patient as mitral stenosis. Now, age of the patient, pulmonary hypertension, heart failure, low cardiac output, all these factors increase the fetal and maternal mortality. Maternal mortality, you can see 3% in severe MS, 1 to 2% in moderate MS. Stillbirth and neonatal death, 2 to 4%, preterm birth, 20%. If the patient is in atrial fibrillation, you have to use heparin throughout pregnancy. And if the patient goes to atrial fibrillation in a pregnant condition, DC cardioversion is the best therapeutic choice. Beta blockers can lead to hypoglycemia, fetal bradycardia, preterm birth, IUGR. Diuretics can reduce the amniotic fluid volume and uteroplacental perfusion. Pregnancy and MS is a big topic to discuss, I feel. Algorithm of mitral stenosis management. So what is that? First of all, severe, and the other thing is progressive. If it is a severe mitral stenosis in the form of a mitral valve area less than 1.5 centimeters squared and a pressure half time more than 150 milliseconds, if the valve quality is good, if the Wilkins score is less than 8, mitral regurgitation is either 1 or maximum 2, you can go for a percutaneous balloon mitral valvotomy. If the valve quality is not good, calcified leaflets, Wilkins score high, better you go for a mitral valve replacement. Rheumatic heart disease, mitral stenosis, it is not good for mitral valve repair. For asymptomatic severe mitral stenosis, same criteria. If the Wilkins score is low, if there is a pliable mitral valve, no significant mitral regurgitation, you can go for a percutaneous balloon mitral valvotomy. If the asymptomatic MS with new onset atrial fibrillation, this is also an indication for intervention, either BMV or a surgery. And the other patients are the progressive mitral stenosis. Simple calculation of the mitral valve area does not always give you an idea of the symptomatic status. Like a lady of having a mitral valve area of 1.7 centimeters square may also have severe mitral stenosis. It depends upon the amount of flow across the mitral valve. So if the patient have exertional symptoms, and sometimes we do a exercise stress test in mitral stenosis patients to unfold the symptoms, So many times, even if the area is borderline, say 1.5 or 1.7, sometimes we do an intervention because this lady may be having other associated symptoms like a hypertensive heart disease, a diastolic heart failure, and many other elements, obesity, and this mitral stenosis is aggravating the symptoms further. So sometimes, even if the area is little more than 1.5, you may have to go for a definitive intervention. So mitral annular calcification, this is a big topic, though we don't study it much, but in Western world, it is degenerative mitral valve disease that is the primary cause of mitral stenosis. So basically, it involves the mitral annulus and the base of the leaflets. There is reduced diastolic annular expansion and leaflet mobility, involvement of mainly the anterior annulus and the A2 leaflet extending more than the half of the length. But in mitral annular calcification, there is no commissural fusion like rheumatic heart disease. There is no subvalvular involvement like rheumatic heart disease. The leaflet tips are free, unlike rheumatic heart disease. So this is the difference between mitral annular calcification and rheumatic mitral valve disease. In rheumatic mitral valve disease, the leaflet tips are involved, the subvalvular apparatus is involved, there is commissural fusion. But in mitral annular calcification, there is only annulus and the base of the leaflets that are involved. Classical signs of mitral stenosis are absent, therefore, in MAC, but there may be reduced LA compliance with increased LV stiffness, which may lead to symptoms. Now, planimetry does not help, therefore. like typical rheumatic mitral stenosis. Because in rheumatic mitral stenosis, you get doming of the leaflets. In degenerative mitral stenosis, you get a funnel-shaped leaflet. The obstruction is mainly at the annulus and at the base of the leaflets. In rheumatic, the obstruction is mainly at the tip of the leaflet. So there is many difference. Extensive calcium can impair the planimetry, and the p-hef time also gets an erroneous result. So continuity equation may give you some idea about the severity of mitral stenosis, that is the CW Doppler. Cardiac CT can also give you an idea about the severity of mitral stenosis. In those patients who have aortic stenosis, 50% have associated mitral annular calcification and 11 to 18% have severe mitral stenosis. And atrial aortic stenosis, remember, it always underestimates the severity of mitral stenosis. So you have to assess the mitral valve stenosis after releasing the aortic obstruction. That is the best way. Symptoms are mostly dyspnea, and the symptoms can also due to the comorbid symptom, because a patient of mitral annular calcification is an elderly and he may have a CKD, he may have a hypertensive heart disease, he may be diabetic, he may have diastolic dysfunction. So there are many other causes which may contribute to symptoms. Severe degenerative mitral stenosis carries a mortality of 32% per year. Not less, no? It's quite significant. And this is what is very common in the Western world. Asymptomatic degenerative mitral stenosis becomes symptomatic 7 to 8% per year. And treatment, there is no satisfactory treatment for degenerative mitral stenosis because it is basically calcium. And debriding the calcium and suturing in the valve annulus becomes difficult. The AV groove can also get disrupted. So you can try a mitral valve replacement, or you can try a balloon expandable aortic valve implantation in the mitral valve, but none of the therapies are very satisfactory in mitral annular calcification. What are the other causes of mitral stenosis? Long-standing radiotherapy not protecting the non-target tissues can cause mitral stenosis. Like 2 decades after radiotherapy, there may be aortomitral curtain or anterior mitral annulus calcification. See this picture. This is the aortomitral curtain and this is the mitral annulus. So all this getting calcified. This is a patient who received radiotherapy before, and radiotherapy is one of the cause of causing calcification of the mitral annulus as well as the aortomitral curtain. Besides, after a therapy, you can also get mitral stenosis like mitral valve repair, after mitral valve replacement, after an Alfieri stitch, or after a mitral clip. So these are all iatrogenic. After a treatment, you again develop mitral stenosis. Degeneration of bioprosthesis. So thrombus, pannus, leaflet thickening, calcification, patient prosthesis mismatch. These are all the various causes of mitral stenosis. So what can you do? A repeat surgical MVR, or you can go for a transcatheter mitral valve in valve replacement. So you also need to remember that in the modern world, the various therapies that are done for mitral valve, like mitral valve replacement either by a tissue or a metallic valve, or the Alfieri stitch, or the mitral clip for mitral regurgitation, all these can lead to future mitral stenosis. Even a thrombus or a pannus or a leaflet calcification in a bioprosthetic valve or a patient prosthetic mismatch, all this can lead to mitral stenosis again. So lastly, this is the procedure of balloon mitral valvotomy. And what you do is basically do a transseptal puncture by the broken bro needle. So what are the elements you need? You need a broken bro needle and you need a balloon, the Inno balloon. So what is the sizing of the balloon? So height by 10 plus 10. Height by 10 plus 10 is the size of the balloon. So this is the dilator. This is the stillet. This is the ruler by which you calculate the balloon size. And this is the main Inno balloon. So what you do? We do a femoral puncture. We do a femoral groin puncture. And you take a long wire, stiff wire up to the superior vena cava, left subclavian vein, and over the wire you take the needle, that is the broken bro needle, and you gradually withdraw the broken bore needle until it falls over the fossa ovalis. Then you change the views, left anterior, right anterior, and lateral oblique to confirm that the needle is just over the septum. And then you puncture the septum and you carry the sheath inside. You take the wire inside, and through the wire you take the inner balloon, and then through the inner balloon you take the stellate, and you manipulate the balloon through the mitral valve, and you then dilate the balloon, and you do the balloon mitral valvotomy. So transeptal puncture, negotiation of the curly wire, taking the balloon over the curly wire, taking the stellate, negotiating the balloon through the mitral valve, inflating the inner balloon to do a balloon mitral valvotomy. That is the procedure how you do it. So I think that is sufficient for today, because too much of slides, it will be taxing on your brain. So discussing mitral stenosis, I think we will conclude today. We will have a next class on mitral regurgitation and aortic regurgitation. That will be fine, I feel. So if you have any questions, let's students, you can ask me. Is there anyone who is listening?
Hello, aspirants. Good evening. Please respond to sir.
Yes, sir.
Thank you, sir. Thank you. This is Dr. Vijit Parmakar from Tata Medical Center, Kolkata. Hello.
Okay, yes.
Sir, one thing just you in the mid of the class, you explained the gap of this some flow. This is mitral. What I couldn't understand that.
Which one?
The mid of the slide. Mid of the slide, you just you told some the parameters. That is some diameter, the gap of the diameter or something.
Diameter of the mitral valve area?
Yeah, mitral valve area.
So the normal mitral valve area is 4 to 6 centimeters square. Normal mitral valve area. So this is, do you mean this slide?
And when we'll tell this is mitral stenosis and significant mitral stenosis,
yes,
moderate or severe mitral
so this is, you can see here that the normal mitral valve area is 4 to 6 centimeters square. If it is less than 2 centimeters square, we call it mitral stenosis. Now previously,
less than 2.
What was the, yes, tell me.
Less than 2 centimeters square.
Less than 2 centimeters square means mitral stenosis. And if it is less than 1, we call it severe mitral stenosis.
Okay, sir. And according to the diseases.
Yes. Yes, can you
According
repeat?
to the diseases, what all types of the severity of mitral stenosis we'll get in rheumatic or other calcification or other things, valvular disease or annular mitral stenosis, which this diameter in statistics wise or percentile wise, what diameter will get in the different diseases?
What diameter?
We'll get in different diseases generally.
Irrespective of the underlying cause, the severity of mitral stenosis only depends upon the mitral valve area. So if by planimetry, you can get an area less than 1 centimeter square, it is severe mitral stenosis. That is irrespective of the etiology.
Okay, sir.
Be it a rheumatic or be it a mitral annular calcification.
Sir, one
and remember,
thank you, sir.
that after doing a balloon mitral valvotomy, ideally, there should be at least 50% gain. Or if the area should be at least more than 1.5 centimeters square after a balloon mitral valvotomy. That is a satisfactory achievement of inflation.
Okay. Okay, sir. Thank you.
Yeah.
Is there any role of closed mitral commissurotomy in pregnant patient?
Closed mitral commissurotomy and percutaneous balloon mitral valvotomy, these are the two options. Now, closed mitral commissurotomy was the surgery which was done in almost very, very older times, prehistoric age, you can say. So there is at present, there is no role of closed mitral commissurotomy because it is mostly a blind procedure and it is a surgical procedure. Instead, balloon mitral valvotomy is a percutaneous procedure which has shown much lower mortality and morbidity compared to closed mitral commissurotomy in pregnant ladies. So nowadays in pregnant ladies, it is balloon mitral valvotomy is the choice, but ideally the time has to be very careful. It should be in between 28 to 32 weeks.
Thank you, sir.
Sir, can you explained very nicely the auscultatory finding in mitral stenosis? Can you
Yes,
explain again that slide?
yes.
That
I will just repeat the
S1,
auscultatory
S2.
findings. So I will
Yes,
just repeat the auscultatory findings. See, when you auscultate, what you ausculted? You ausculted the heart sounds, you ausculted added sounds,
yeah,
and you ausculted the murmurs. So first of all, coming to the heart
yes, sir.
sounds. First heart sound and second heart sound. So in mitral stenosis, the first heart sound S1 is loud. Now why S1 is loud? You are asked. So the
Yeah.
loudness of S1 depends upon the velocity with which the valve is closing and also the distance the valve has to traverse during closing. In mitral stenosis, the valves are wide open for a very prolonged time because the LA-LV gradient remains high for a long time. So the valves remain wide open for a long time. And then when the LV pressure rises, there is a wide excursion of the valve leaflets and there is a high cooptation velocity of the valve leaflets. All these lead to a loud S1. Second is second heart
Okay.
sound. Now, second heart sound has two components, A2 and P2. Now, mitral stenosis often leads to pulmonary artery hypertension, for which the P2 component gradually becomes loud. Now, normally during inspiration, we can make out the split of A2 and P2. As the pulmonary hypertension develops, the A2-P2 gap gradually lessens, and ultimately the A2-P2 merges together, and there is a single loud second heart sound due to loud P2. Next is the added sound, which we call opening snap. Now, opening snap, it is the sound that is produced due to abrupt halting and tensing of the mitral valve leaflets during diastole. Opening snap is a high-pitched sound, which is best audible just inside the apex. Now, the A2 opening
Okay,
snap
sir.
gap is an indicator of the severity of mitral stenosis. A2 OS gap has two components. One is A2 to the onset of mitral valve opening, that is A2 MO gap. And next is the MO OS, so mitral valve opening to the proper opening snap. Now, it is the A2 MO gap that signifies the severity of mitral stenosis, ideally. And next is the murmur. We describe this murmur as a mid-diastolic rumbling murmur with presystolic accentuation, which is best audible in left lateral position with breath held in expiration with the bell of the stethoscope. So that is the classical description of MS murmur. But if the patient goes to atrial fibrillation, the presystolic accentuation is lost. We only get the early diastolic component. If there is a pulmonary hypertension, you can get a murmur of pulmonary regurgitation. And if the patient has a pulmonary artery hypertension, you can also get a murmur of tricuspid regurgitation. So any more questions?
Okay, sir. Thank you. Thank you, sir.
So if there are no questions, then thank you very much, all the students, for your patient hearing. Thank you.
Thank you, aspirants. Have a nice evening.
Thank you, sir.
Thank you all.